I'm gonna borrow your just to test real quick. Testing, Brian, can you hear me?
Hey, Sam, I'm ready when you are. Yep. Thank you, Sam. Good morning. I'm Raul Garza, and I serve as the chair of the Cook County Health Board. And first thing I want to do is wish everyone a happy holiday. I hope everyone enjoys the time with your family, loved ones, and you're able to rest. So we'll start out with the roll call, and well, first let me call the meeting to order, and then ask the secretary to please take roll.
Director Bott?
Present.
Director Green? Present. Director Harrington?
Present.
Director Kim is absent. Vice Chair Lowry is absent. Director Masuda Barnett? Present. Director Ryder is absent. Director Robinson?
Present.
Director Sorrell? Present. Director Stain? Present. Director Webster Cross?
Present.
And Chair Garza.
Present.
You have a quorum.
Thank you, Madam Secretary. So I'd like to ask for a motion to allow Director Mia Webster Cross to remotely participate in this meeting as a voting member. Have a motion?
So moved.
Thank you. Thank you for the second. Any discussion? All those in favor?
Aye.
Aye. Any opposed? Okay, thank you. We'll move right down to item 3 with employee recognition. And happy to welcome Pat Caceres, who will be in place of Dr. Eric Curtis this morning to take that honor on to recognize our employees, please.
Thank you, Chair. Good morning, everyone. Pam
Good morning.
Caceres, Chief Financial
morning.
Officer. As Debbie pulls that up, I'll go through employee recognition. We're going to welcome our new leadership hires. Apologies for any butchering of names right off the top. It's
Taking its time.
All right. Starting with new hires. We welcome Nick Shields, Chief of External Affairs and Civic Engagement, Samantha Burke, Centers of Excellence Manager for Patient Experience, and Simone Rush, Nurse Coordinator 2 at CERMAT. We also have some promotions. We'd like to congratulate Michael Davidovich, Associate Medical Director for Primary Care at ACHN, Dipte Dige, Chair of Division of Pediatric Hematology and Oncology, and Lisa Thompson, Residency Program Director for Ophthalmology. Moving on to recognition and announcements, we'd like to, proud to announce that the Pediatric Dental Clinic at Belmont Cragen is now open and accepting new patients. On November 6th, we held a press conference to announce exciting news and reaffirm Cook County Health's commitment to ensuring that children have access to comprehensive, compassionate care. Congratulations to the entire team, and if anyone's here, please stand up and be recognized. Thank you. Next, we have our behavioral health crisis report. Cook County leaders gathered this week to recognize the release of a report, Community and Provider Voices, Strengths and Opportunities in the Suburban Cook County Crisis Care System. The report, authored by Cook County Department of Public Health and the Cook County Just Advisory Council, is a comprehensive local assessment of the behavioral health crisis system that presents findings from community members, behavioral health providers, and social service providers. Next, we have apologies, yes, please be recognized. Next, we have the American College of Surgeons National Surgical Quality Improvement Program, which recognized Stroger as one of the 76 participating hospitals that achieved meritorious outcomes for surgical patient care in 2024. The 76 hospitals achieved the distinction based on an outstanding composite quality score on one or both of the grouping categories, all cases and high risk. Congratulations to the entire Stroger team, and again, please stand if you're here to be recognized. Next, we have congratulations to Dr. Natalia Pike. I'm going to murder this one, Peisler, for being elected by thousands of cardiologists across our great state to serve as the next governor of the Illinois chapter of the American College of Cardiology. She's the first CCH cardiologist to ever serve in this capacity. Congratulations on this recognition. And if you're in the room, please stand up. Not seeing it. And last but not least, why he's hiding today, no, I'm just kidding. Congratulations to Dr. Eric Makaitis for being one of the leaders included in Crane's Who's Who in Chicago Business List for 2025.
Thank you, Pam. We'll move to item number 4, public testimony. Madam Secretary, have any speakers registered to provide a virtual or in-person testimony or sent written testimony to be included into the record?
We have one registered speaker, Dr. Claudia Fegan. She also provided printed copies, which will be included in the record of her testimony that she'll be providing.
Okay, I'd like to welcome back Dr. Claudia Fegan, who served many faithful years with the Cook County Health System. So it's nice to see you, Dr. Fegan. Welcome back.
Thank you. I appreciate the opportunity to address the Health System Board. I have been a member of the medical staff of Cook County Health since August of 2000. As many of you know, I retired as Chief Medical Officer for Cook County Health last year. I love Cook County Health and was proud to have served here for all my years. I still feel like this is home for me, which is why it was important to me to maintain my medical staff privileges when I retired. So although I am no longer employed, I am still a voluntary member of the medical staffs of Providence and Stroger Hospitals. In retirement, I have remained a strong advocate for the health system in my voluntary role as National Coordinator of Physicians for a National Health Program and a member of the Board of Health and Medicine Policy Research Group. 2 weeks ago, a member of the medical staff of Stroger Hospital told me that they had received notice that CCH would begin charging uninsured patients for COVID vaccines. I said I found that hard to believe. I asked them to forward the notice to me. I attempted to find out if such a thing could be true. I have subsequently learned the decision to charge patients had apparently been reversed. However, this week I learned the medical staff member who shared this information with me was told that she would be required to write a written letter of apology for sharing the memo and to promise not to do it again. While many of us have been appalled by the authoritarian approach we have observed in the current federal administration, we have taken heart that we live in Illinois, where we would like to believe that there is a more thoughtful approach to governance. I am trying to understand why on earth would a member of the medical staff be admonished for leaking an internal memo to another member of the medical staff. Cook County Health has a medical staff of over 1,100. What on earth constitutes an internal memo? Do we honestly believe a memo for the entire medical staff is somehow a secret? Cook County Health is a public entity and subject to public scrutiny. There are no secrets. Finally, there's a federal statute that requires healthcare entities to clearly post their charges. Every patient should be informed of the cost of the care they receive. This is something with which we have always struggled to comply. The idea that my inquiry about whether CCH intended to charge patients for COVID vaccines would prompt us a search for the leak is more than disappointing. I would have preferred an emphatic reassurance to the staff that we recognize the ongoing public health threat of COVID. And of course, we will continue to provide the vaccine to those who need it and cannot afford it. First of all, as a member of the medical staff, I was entitled to the information shared. Second of all, I am not now and have never been a threat to the organization. As a matter of fact, when I left in December, many told me I had been an asset. So my question for the leadership of this board is, at this point, what are you trying to hide and why? Thank you.
Thank you, Dr. Fagan. I'll ask the executive staff to look into this immediately and report back to me by next Wednesday on the circumstances. So thank you. Is there any further testimony?
No, Chair.
Okay, thank you. Okay, we will now move to item 4, board and committee reports. So the minutes of the October 31st, 2025 board meeting, I'm presenting those, and I'm asking if there are any corrections that need to be made, need to be made or needed. And I'll do that through the motion. So is there a motion to approve item 4A, the board meeting minutes of October 31st, 2025?
So moved.
Second.
We have a first and second. Are there any corrections or any discussion on the minutes, please? Hearing none, all those in favor?
Aye.
Aye.
All those opposed? None, the motion carries. Thank you. Now we will move to item 4B, which are the minutes of the November 13th, 2025 Human Resources Committee meeting, and I'll pass that over to Director Sorrell.
Thank you, Director, and I'm honored to be serving as now the chair of the committee and the first woman chair of a committee here in the board. Thank you.
Yeah, forgive me for not recognizing that, but yes, you and I spoke about it, and I was very grateful that you welcomed the opportunity to serve in that role. So I know you'll do great things to help support the staff. Thank you.
And will do my best to follow in your footsteps. Thank you.
That'll be easy. Thank you.
And the Human Resources Committee met on Friday, November the 14th at 11:30 a.m. The committee's regular meeting schedule for 2026 has not yet been determined. However, it is expected that the committee will begin holding their quarterly meeting starting in February of 2026. The committee received the report from the Chief Human Resources Officer, which is included within the minutes, and included information on the following subjects: demographics for all CCH employees, talent management, our metrics, our in current state of agency use, which showed remarkable decreases in the percentages of agency use so far, the accelerated hiring process, fiscal year 25 CCH turnover rate, sourcing strategies, recruitment process steps, organizational and workforce development measures, onboarding, CCH Leadership Institute for all employees, and leadership development. During the discussion of CCH employee demographics, a request was made for a breakdown of the demographics of those staff in leadership positions, so we can monitor that as well. If there are no further questions, then the minutes are being presented for consideration at this time, Director.
Thank you, Director Sorrell. So I'm asking for a motion to approve item 4B, the minutes of the meeting of the Human Resources Committee of November 13th, 2025.
So moved.
Second.
There's a second. Is there any discussion or corrections to the minutes? Okay, there are none. All those in favor?
Aye.
Aye.
All those opposed? Okay, that motion carries. We will now move to item 4C, the minutes of the November 14th, 2025 Quality and Patient Safety Committee meeting. And I will turn that over to Director Webster-Cross, please, to review.
Hi, good morning, everyone. I am here presenting the Quality and Patient Safety Committee meeting minutes. That was from November the 14th at 9 a.m. The committee approved the following action items, which are included in the minutes. They approved Stroger and Provident Hospital medical staff appointments, reappointments, and changes. The committee received the following reports, which are included in the minutes: Operations Excellent, Dashboard Goals and Tactics, the regulatory report as well. The next meeting of the committee will be held on Friday, December the 12th at 9 a.m. If there are no other questions on these minutes, they're being presented to the board for consideration. at this time. Thank you.
Thank you, Director Webster Cross. So I would like to ask for a motion to approve item 4C, the minutes of the meeting of the Quality and Patient Safety Committee of November 14th, 2025, which include approval of the following items: Stroger Hospital and Provident Hospital medical staff appointments, reappointments and changes. Do I have a motion, please?
So moved.
Thank you.
Second.
Thank you. Is there any discussion or correction to those minutes, please? Hearing none, all those in favor?
Aye.
Aye.
All those opposed? The motion carries. Thank you.
Thank you.
We will now move to item D, the minutes of the November 13th, 2025 Finance Committee meeting.
I've got two.
Okay. All right, Director Ryder is making his way in, so I'm going to ask my colleague, Director Harrington, if you can step in to review those, please.
Thank you.
Thank you.
Finance Committee met on Thursday, November 13th at 10 a.m. The committee considered the following action items which are included in the minutes. Conditionally approved 19 contracts and procurement items. Request number 9 was withdrawn. Numbers 3, 11, 16, and 17 pending review by contract compliance. On the screen, you'll see the contractual requests from the Finance Committee meeting whose financial impacts are greater than $1 million, which are highlighted for your information. We received and filed grant award-related items. The committee received the following reports, which are also included in the minutes. Quarter 3, report of contracts executed under authority of the CEO, report of 4 emergency purchases, report of September financials, monthly report on agency reduction plan. Following the review and discussion of the financials, it was requested that Mr. Galliner walk through the wellness initiatives and the benefits of county care members at the next board meeting in December. The next regular meeting of the Finance Committee is scheduled to be held on Thursday, December the 11th at 10 a.m. If there are no other questions, the minutes are being presented for the board's approval at this time.
Thank you, Director Harrington. So I will ask for a motion to approve item 4D, the November 13th, 2025 Finance Committee meeting minutes, which contain the following action items: conditional approval of the contracts and procurement items pending review by the contract compliance, and receiving and filing of the grant award related items. Can I have a motion, please?
So moved.
Second.
Thank you. Is there any discussion or corrections to the minutes? Hearing none, all those in favor say aye.
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 All those opposed? Okay, that motion carries. Thank you. We'll move to item 5, contracts and procurement items. There are none being presented. So that'll take us down to item 6, which is a report from the chair. So we heard Pam highlight a number of things, great things that are happening at the Cook County Health System, but I had the opportunity to attend 2 of them. The Belmont Cragen Health Center dental clinic opening, which really have a focus on pediatric dental, and I have to say I was very impressed. I have not been to the Belmont Cragen Health Clinic until that visit a few weeks ago, but you know, the need that exists just in general, but certainly in that area, it's pretty profound. So it's just another example of the commitment that the system is making to help the community. And then I thought the work, the collaborative work that was put together by both their own Cook County Department of Public Health, led by Dr. Joshi, who we'll hear from in a few minutes, and the Cook County Justice Advisory Council on this comprehensive behavioral health crisis report that really, I think what it does is it illustrates the fragmentation with confusion by patients, you know, knowing where to go, when to go, and really what they're going to get back. And I think the report itself is a roadmap to strengthening a system, and I think the county sits in a position to be able to really help bring a better coordinated, and something I'm hammered on is a better integrated system of care that brings both primary care and behavioral health together. And I was happy to say that there were several board members that attended that press conference where that report was issued and spoken to. So if you have an opportunity to attend these events, you really get a great sense of what's happening in every corner of the county health system on behalf of the Cook County residents. So if time allows, please try to get out and support those events. That's all I have from our report. We'll move back to Pam on item 7, and she will review a number of items for us. Pam?
Sure, thank you, Chair. We have a couple updates and presentations for you today. The first update on ARPA obligations, I believe, is in your packet for you to receive. And then next item, if there's no questions on that, is to move to a Stroger update from Donica Austin Kathy, Chief Hospital Executive for Stroger.
Excuse me, Pam. I'm sorry, but I don't see the ARPA update.
Debbie, do you want to share? Okay.
So the ARPA update was sent to you electronically. It wasn't printed for the packet
Okay.
because we weren't going to review it today.
Okay.
It'll be in the packet that goes out to you again after the meeting.
Thank you. Thanks.
Sure, just a comment though, again, all the funds have been obligated. We're just in the process of getting the monies paid out by the end of next year.
Okay. Thanks so much.
Sure. Sorry, Donica, go ahead.
Thank you, Pam. And good morning.
Good morning.
Thank you, Chair Garza and directors for the opportunity for us to share an update on Stroger. With me today are my amazing leaders. To my right is Dr. Jacqueline Witten. She's Chief Nursing Officer for Stroger. And to my left, Dr. Ruda Kamapli. He is Medical Director for Stroger. Okay. I'm going to start by giving a little bit of the history of Stroger. As many of you know, Stroger has a legacy of equity, established to care for all county residents regardless of the ability to pay. And this really dates back to the 1800s. In 1866, the first patient at the original Cook County Hospital is a young immigrant girl from Germany with an abscessed hand. By the 1920s, Cook County Hospital patient population became majority African American as racism and exclusion persist in healthcare. Mexican immigrant and chair of family medicine, Dr. Jorge Prieto, began making house calls in the immigrant communities in 1952. And also, our first community health center is named in his honor. Cook County cared for one patient suffering from abortion complications. This was pre-Roe versus Wade. And after the legislation, the hospital funded up to 4,000 abortions annually. We opened the first comprehensive trauma unit in the United States in 1966, and we became home to the first blood bank in America 88 years ago by Dr. Bernard Fantis. Chicago's first AIDS and HIV clinic opened in Cook County Hospital in 1982, and the clinic served a third of the Chicagoans living with HIV in the early 1990s. Also, in 1986, Dr. Agnes Latimer was named Medical Director of Cook County Hospital and named the first African-American woman Medical Director of the major U.S. hospital. The new hospital, as you see it today, was named after the first African-American president of Cook County Board of Commissioners, John H. Stroger Jr. Hospital. We are incredibly proud to be the flagship of Cook County Health with 450-bed teaching hospital serving as a hub for Cook County for the delivery of specialty and subspecialty care. We continue to invest in the growing access to modern, high-quality care. And in the last year, we opened the Neurosciences Intensive Care Unit, as well as launched the robotic surgery program. We are incredibly proud of the recognition. There have been many across our organization. One that stands out as we were recognized by the U.S. News and World Report as a high-performing organization for chronic obstructive pulmonary disease, heart failure, heart attack, kidney failure, and pneumonia. These ratings were based upon the several factors, including the patient outcomes, patient safety, nurse staffing, and many, many more elements. Also, as you see here today, and again, we are incredibly honored by almost a dozen or more recognitions that we receive over the years. The first one is Stroger has been named among the best hospitals in Illinois from Newsweek, our global hospital status, Women's Choice Award for the cancer program, the Castle Connolly for top hospital in our procedures for hernia repair and mastectomy procedures, and also recognized by the Lawn Institute for Hospital Racial Inclusivity, #1 in Illinois and #2 in the United States. Thank you. We are incredibly proud of our work in patient safety and clinical outcomes, and Stroger has maintained its grade of B from Leapfrog in the most recent grading period. The Leapfrog safety is the hospital rating focused exclusively on hospital safety and ranks over 3,000 hospitals across the United States. I do want to point out that we are incredibly close to an A. We're 0.18 away from an A.
You gotta get it. That's right.
Moving to our accreditation, our hospital accreditation and certifications are incredibly important to us. They help promote patient safety and our quality of care, and they really demonstrate our commitment to patient safety, high quality, as well as our continuous improvement. And as you see before you today, we have hospital accreditation and healthcare equity certification that we received this year from the Joint Commission. This year, we also have advanced certification for primary stroke centers by the Joint Commission and also the American Heart Association. We received numerous accreditations from the American College of Surgeons, the American Comprehensive Cancer Center, our level 1 trauma verification, which happened this year, as well as our metabolic and bariatric surgery accreditation. We also have a designation from Illinois Department of Public Health for our level 3 NICU, as well as our level 1 adult and pediatric trauma center. We have accreditations in our laboratory from the College of American Pathologists. We also received this year the Pharmacy Division Full accreditation from the Utilization Review Accreditation Commission and the American College of Radiation, and many, many more. As you see before you, we've just laid out it shows the breadth of the clinical services across our organization. Really everything from our ambulatory care to some of our specialists in gastroenterology, hematology, neurosciences, pulmonary, trauma burn, general surgery, and of course, all of the subcomponents under our surgery. And now I will pass to Dr. Whitten and Dr. Knopfley to share some of our key statistics, as well as our work in quality and safety and experience.
Thank you, Donica. We are proud to be a large safety net provider. As you see here, these figures not only highlight the breadth of our services, but also underscore our commitment to ensuring every member of our community has access to excellent quality, compassionate care. If you look, home of 24 residency and fellowship programs, they're coming in, getting wonderful, great experience to be able to provide the care that they need. We see over 16,000 inpatient discharges for 2024. More than 95,000 patients come into our emergency room and our trauma visits where they get a second chance at life. Also, we're stabilizing, making sure that we can get them back into the community. You also see nearly over 850,000 outpatient registrations, which mean they're provided the care and resources that they needed. more than 550,000 outpatient prescriptions filled at Stroger, which means we're stabilizing their health needs for them to get the medication that they need. Also, over 11,000 surgeries annually, as you can see, to correct and extend patient lives to go back home to their families. Over 1,171 deliveries in 2024, which are memories, and close to 90,000 inpatient and outpatient rehab visits, which really mean behind all the statistics is a person, a patient, a family. It's a story to tell, the trusted source of the care that we provide. Going to the next slide. As you can see on the next slide, our success is measured not just by what we do. When we think about it, it's about the experience, it's about our outcomes. We create every moment for these patients, and it's really centered around the patient care that they receive. These are just 4 domains that guide our daily work that we work every day and focus on, which is our 4 domains under quality, safety, and the patient experience. It's patient experience, clinical outcomes, readmission, and throughput. I'll just share a few things with you regarding the patient care experience. We're proud to announce that our physicians have exceeded goals by exceeding over the 85th percentile when it comes to physician communication. That says a lot for our patients and our community when they speak. Nursing is right behind there, exceeding their goal this year too. Top box with 76% when it comes to the patient and nursing communication. We have a robust team that's working with us to really focus on the compassionate care here at our organization. We're excited, and that's just to name a few. When it comes to the clinical outcomes, I'll share a few just high level. When it comes to the central line associated bloodstream infection known as CLABSI, not sure if everyone knows this, but we're better than state here at Stroger Hospital, which says a lot for providing great care. When it comes to CARDI, which is your catheter-associated urinary tract infection, we're beating out state and national. That says a lot from preventing infections here in the organization. And these are just a few of the notable ones that I'll share at this moment.
Thank you very much, Jackie. So, adding to the clinical outcomes, our mortality rates remain extremely low, around 1.3%. A significant proportion of that, though, is due to patients who are really at the end of life, or they have advanced cancer and so on in other places. So if they were insured, they would have gone to a hospice or something. But unfortunately, they end up dying here. But we are making arrangements to have a general inpatient hospice facility. This is a program we are working on. And also sepsis, which has an extremely high mortality, has been something that we have been greatly focused on. We had been trying to get a sepsis coordinator for years, and I'm proud to say this year we finally hired a sepsis coordinator. Now, I was excited to see Dr. Fagan here today, my mentor and a phenomenal leader. Now, as we tell the stories about significant improvements in Stroger, she was behind them. I still remember when she called me to her office in 2016 and talked about we need to fix certain things here, throughput, and UN. So we needed to take over things and make sure things happen. I must admit, I evaded her for about a year, hoping she would forget, but Dr. Fagan never forgot. In 2017, she called me again and said, it's time to take over, we need to do it. And it's been a journey. We've done exceptionally well. With readmissions, I'll tell you, the average hospital readmission for U.S. hospitals is about 14.67%. Illinois is among the 5 worst states with readmission rates. We have 15.02%. Now, Stroger Hospital, we are at 9.4% for admissions to our hospital and 13% for all cross admissions, which is patients we saw here who went to other hospitals. So that just shows you the phenomenal work we are doing. Now, this is on the background of having operational and financial constraints, but we are beating the bands of several people. Now, with regards to throughput, which is how effectively we move patients through the institution, through over the past few years, from leadership, again, stemming from Dr. Fagan, the rest of the team, building the team, teamwork, focus, and commitment, we have significantly improved. Left without being seen, you all have heard, which basically refers to how many patients will come to our ED and then leave without actually getting the care. It wasn't that long ago Now we were at 10%. That means that out of every 100, 10 left without being actually having the care they needed. The highest number I personally was aware of in the last 4 or 5 years or so was 17%. What is the national benchmark for all U.S. hospitals, whether you're 2-bed ED or 1,000-bed ED? 2%. What's the Chicago Cook County number? 4%. What's Georgia's number? 1.3%. And I challenge anybody to give me an example of a large urban hospital, safety net, who is putting down these numbers. And we have sustained this since we started this significant improvement journey in October 2022. And here we are very proud. And several days we actually go with 0%, which is nothing short of impressive. Other ED throughput metrics have improved. And I must say, you must see the glowing letters we get from our patients. The numbers don't just tell the story. The letters speak to a lot of stuff. So efficiencies have improved, timeliness of discharge has improved, and our rolling 3-month averages for inpatient and observation care have significantly improved. I will hand it over.
Okay, thank you. Next slide. Let me take a moment and brag on nursing, quality, safety, and service. Just a few things I would like to share with everyone. The nursing has successfully established a robust nursing excellence around the patient pathway to excellence, which means we bring our nurses to the table. They're fully engaged. They're focused on their shared governance and really sharing with us some things that they feel are best practices. We're very proud of that. We're also excited to go to the front line. We have Stroger has 9 dynamic nursing safety coaches to help with managing, speaking up for safety, to make sure that we're focusing on the culture of safety. We've already talked about Stroger nursing quality sensitive indicators outperforming national and state benchmarks, so kudos there. And this week, successfully, it took a whole village and team to roll out the TeleCity technology, which is enhancing patient safety. And what really matters the most, that shows to me not just safety, but we were able to take bedside staff so they could go back to the unit and care for patients while patients are being monitored virtually. So just kudos to the great work that's being done. Going to our next slide. We're going to talk about a little bit about workforce. As we all know, it's one of the greatest assets that we have here at the organization. Our engagement scores give us a very clear picture of where we're at now and where we're going to the future. I just want to highlight a few things so everyone will know. When this survey was taken, we excelled at, I would like to be working at Cook County Hospital 3 years from now. That says a lot. From 2022, we jumped up to the 42nd percentile. I would like to stay with the organization if offered another similar position here. We exceeded and excelled in that question. And I'm also proud to tell people that I work at Cook County. We also excelled with that bullet point. So just kudos there. What we're doing is we're going to look at our action plan, and some of the things we're focused on is the engagement results were shared all the way to the front line so they can know the questions. The leaders are collaborating with the staff to come up, in which we do have an action plan, and leaders are reinforcing that every staff member voice and perspective is valued, and just making sure at the bottom line everybody knows we care, and that it takes a village here to provide the care that's being done. Thank you. Donna, I'll turn back to you.
Thank you so much. The next slide shows our workforce. We are very proud of the diversity of our staff members. As you can see, we've provided a breakdown of our race and ethnicity, as well as gender of our employees, and this is as of October 31st of this year. We have seen significant improvements in our Stroger vacancy rate at 21%, and as well as our turnover rate. Both are much better than our scores were last year at this time. Many accomplishments, and Jackie alluded to, so we've onboarded over 50 new nurses, and we've seen a decrease in our agency spend. Many of the clinical and non-clinical areas are less than 2% in agency, and we're excited to bring on new staff into many of these areas. We see our opportunities as continuing to strengthen our non-clinical services and operations. We're incredibly proud of the partnership that our Stroger leaders have with Human Resources, in continuing their focus on hiring. We're continuing to collaborate with human resources, obviously, to keep employee turnover low, as well as retention and implementing many of the engagement programs that Dr. Whitten alluded to.
Donica, I think you answered the question that I was going to ask about the correlation between the turnover rate and the previous slide on engagement, the engagement culture that has been created. What was the stat a year ago? Because that is extremely low. That's incredible. That's
The turnover
incredibly
rate.
impressive. Yeah, the turnover rate.
The turnover rate this year is 7.4,
Right. I see
and
that.
2024 is 9.4.
I mean, still very impressive. Excellent work. Thank you.
Thank you. And moving to our fiscal resilience, and this is really, the things that we're doing and putting in place to really enable the expansion of our mission, using our resources, wisely, and making sure that we're, as I mentioned, targeting a reduction in our agency spend across our organization. Really optimizing our length of stay. We've seen some significant improvements, almost shaving off a day in our length of stay. Efficiently managing the length of stay really continues to, help us with our expenses, whether it be supplies or staffing. And we're also, as Dr. Cloppley mentioned, focused on our throughput initiative, really improving that flow from admission to discharge, and really where we have some bottlenecks, focusing on those and continuing to drive efficiency.
Thank you very much, Danica. Continuing on with regards to overall operational efficiency. We've had significant improvements over the years. Now, I would say from March 2025 till now, on a month-by-month comparison, we've exceeded discharges every month if you compare between 2020 and 2024. And we're actually on track to have the highest number of discharges over the last 5 years. And we've been able to do this due to a number of things. Operational efficiencies have significantly improved. We're able to get our patients to the ward earlier thanks to our bed control team. We have daily bed huddles to assess our capacity and what we need to do. Staffing has significantly improved. We have surge alerts, and thanks to the leadership of Donica, our EVS and transportation systems have greatly improved. Now, I would say with advancements of medicines over the past several years, we can have X-rays, labs, surgeries, and various things on an outpatient basis. And the singular reason why a patient gets admitted to a hospital is because of around-the-clock care. That is the only thing we cannot provide outside. So that is why it's very important to ensure that our hospitals have excellent and adequate nursing care. Stroger has always been known for the exceptional physicians and the care they provided, but there was always a but. I would say in the last 4 years, we have come a very long way, and is very proud. I'm very proud to say that but no longer exists. And what Stroger nursing has become is nothing short of exceptional. And I would again say, if you haven't read some of these letters which our patients are writing, you should. Now, what is the reason for this? It's no longer any reason why we should keep it a secret. There's a singular reason, and we have greatness in our midst. Our CNO, Jackie Whitten-Bale, came in here and she transformed nursing. She changed what it meant to be a Stroger nurse. Her team believed, and her mantra of safety, quality, and service, they bought into that. You should see the joy on the faces of our nurses who have worked extremely hard, and she's been able to build teams around herself and then brought everybody together. This more than anything, I've been here since '93. If you say what is the biggest transformative change I have seen, it's in our nursing, and it's because of Jackie Jackie Wheaton right here. And it's important that we recognize her. And I would also tell you, so there's a benchmark. A physician has written an order for a patient to be discharged. How long should it take for the patient to leave the hospital? The national benchmark is 120 minutes. For years, we were struggling with 160 minutes. For the past 2-3 years, we are at 80 minutes. And I'm not sure of any large hospital outside which is pushing out this. Going on to utilization management program. This is one of the most important programs and departments in the hospital, because their work, among other things, ensure that we are not just providing free care, we are getting bills for our services. And many may not be aware, it wasn't 5 short years ago that there were significant discussions to essentially disband that program. But I must say, where we are now, again, I'm glad Dr. Fagan is here to hear it, because I'll give her the credit. We have a mature and exceptional program. These folks are responsible for ensuring the correct admission status. When a patient comes in, is he going to be admitted in observation or is he going to be inpatient? They make those determinations, because our payers are very quick to deny you. Say, oh, you put in an inpatient, they should be observation. So they make sure that those things are right. They assist in notification of payers that the patients are here, to submit the clinicals to the payers and arrange and expedite discharges of our patients to nursing home and long-term care facilities. We now have a full department led by Medical Director, Dr. Butoshu, and Helena Gomo is the Director of She is over the case managers, the nurse coordinators, and our transfer center. And Cassandra Waddington is the Director of Inpatient Coordination and over the social workers. The significant improvements in these programs has resulted in our average daily census for the first time this year, which is 303.7%. This is the first time in the last 5 years that there has been a year-over-year reduction. Now you would think that, wait a minute, we want more patients in the hospital. But the fact of the matter is that we want the right patients in the hospital. It doesn't serve any purpose to have patients who are here occupying a bed when they do not actually need to be here, and they're using it as a tenant space. Those were what a significant proportion of our long-stay patients were. 75% of them needed to be here because of their illness. The other 25% could have been sent to a long-term care facility or a nursing home, but they didn't have any insurance and they left here. But by the work of this program and some creativity, we now have an opportunity to be able to transfer several of them out. So because of that gap, the reduction in the number of long-stay patients, the actual average day census has gone down. And that has got financial and operational implications, because then you don't need that many nurses. We are not that stretched anymore to try and then be caring for people who don't really need to be in the hospital. We also have, so the UN team also work on denials management and so on. So they work peer review, they talk to the folks and to make sure that those inappropriate denials which are thrown at us, we contest it. So we've come a very long way from a department which was going to be disbanded to one which is the talk of the hospital. I'll hand it back to you.
Thank you. And our last slide just really talks about our transformation and growth. Obviously, as you heard today, our goal is to continue to transform the delivery of care to really ensure that patients have safe, quality, excellent, compassionate care every single time that they walk into our doors. We're continuing our focus on that quality, safety experience. We certainly want to continue to be a place where people want to work and maybe get an award for employer of choice, right? Achieving our high rating of the Leapfrog Safety Grade and the CMS Star rating. And it's not really about chasing the number, but again, about every single person when they come into that they really get excellent quality care. Decreasing the patient wait times and focusing on our throughput optimization. There's the surgery optimization team that's going on, including growing our surgical volume, as well as looking at achieving operational efficiency, the start time, turnaround times in the OR, growth in our key service lines, and then really the capital investments for Stroger, not only our building improvements, but also the capital projects that we have in our partnership with downtown, as well as our radiology capital replacement plan that will be over 5 years with new equipment. And with that, I want to take the opportunity to, again, thank my team and thank you all for the opportunity to provide an update on Stroger.
Are there any questions or comments? Yes. Director.
So first, thank you all for this report, and thank you for highlighting the great work that's being done. Much like Chair Garza, I had a question about the benchmark of being below 2%. Dr. Kamafli, how many years have we been below 2%?
So we started a significant improvement in October 2022, and I think about a year after that.
Okay,
And then and we've sustained, we've been way below the 2 for at least a year and a half or so. And like I said, several days we are 0%.
Okay, so I always try to, when we're looking at benchmarks, so the benchmark we're looking at today, we're actually looking at that benchmark about like a year back. So since 2022, we would look at 2023 and things like that. So we've been below 2%, which is a good thing, right? Since 2023. Is that what I'm understanding?
Yeah, since about
Okay.
2023. But I would even say the 2%, and that's why I gave the Illinois number. The Illinois numbers,
Higher.
be it Northwestern, U of C,
Yeah.
name any big place, we're in the 4%.
Mm-hmm.
Because you can imagine if you are a small 4-bed, a small emergency department in Berridge, you can't compare the same thing to
Yeah.
here. That 2% is for every place.
Mm.
But then to that point, it was never fair to use that as our benchmark.
Yeah.
So it used to be 4%.
Okay.
But now, even that national, which measures every hospital, we are even way, way below that.
Okay, that's wonderful. That's wonderful. So thank you for all of the work you've been doing. Yeah, that's all. I just wanted to get the years on that.
Yes, Director Sands.
I also just want to add my thanks for the work, the really tremendous work and growth that you guys are doing. What do you think is going to be the focus to get to that A? We're so close in the leapfrog rating. And is there anything that we, the board, can be doing to help support you in getting there?
Well, thank you so much, Director Sains. First of all, the board has been incredibly supportive of the work that we're doing. And in our reports to the Quality Committee as well as the Finance Committee, there's always the question of what can the board do, and we appreciate that. I think in terms of, getting to that A, it's really going to go back to that quality, safety, and experience. It's the consistency across the board at every level in our organization, so that once we get to that A, we're consistent, right? We don't want to move around. At every level understands and knows what has to happen. And really, operating at the top of their license for our clinical team, as well as our support team, and understanding the importance of their roles in providing excellent care to patients.
And
I
I
would
know
also like to add to that since it was asked. We've had improvements in several domains. And as I have said, we are cash-strapped, resource-constrained. So there are clearly things that we can do. Patients don't have to wait inordinate hours or days to have an echo, MRI, or CT, and those type of things. So those are some of the stuff. So if we think we are getting patients early now, can you imagine if we could shave some of those times? And I have also not been one who is a fan of necessarily chasing these scores, like the leapfrog and the rest. We've seen some of the hospitals which are leapfrog, A and so on. And at the end of the day, with the whole good hearts law and everything, when there's a metric, then people are, you are gaming, you are chasing the numbers versus actually having real improvement. And as I have talked about several of the things, we are doing much better than any place in the state or most of them. But when it becomes, then sometimes we would improve something here just to try and get this little percentage, and then things go awry. But real fixes are what are important to me. And as I have often said, we actually know what we need to do for quite a number of those things. And just frankly, I'll say it, we are not doing them. We know what needs to be done, we are not doing them. So I'm sure as we continue to work as a team, we will get those necessary resources and so on that we need to do. We know what we have to do. I'll just leave it at that. Thank you.
Thank you. We'll go to Director Bott and then Director Maya Green. And then back to Director Harrington.
Thank you, Mr. Chair. One, just thank you for the tremendous work and effort in advancing and supporting the health of our county residents and those that come to our facility, and just want to applaud that. And I think this point that you all just made about sustained improvement and consistency is critically important. So whatever, I think the Quality and Patient Safety Committee can do to support that, we're here for it. The question I'd ask is, are there, when you think about systems that are designed to achieve the results they're designed to achieve, I often hear that. So what do you think are some of the things, Dr. Kamapala, you're articulating, there are things that we know we need to do. Are there different things we might need to do to impact the system so it leads to different results than ones that we've consistently been getting? And we don't have to necessarily answer that here, but that's a question I think about in the context of, what the committee and what this board can help support.
Okay.
Thank you. Director Green.
One of the things I was just reading about in a healthcare, a hospital, kind of journal that I touched base, I think, with, when at the meeting last week, but, I think it was slide 23. I love that we're looking at our workforce and, different experiences. One of the things I think may be of value is to look at, it's 23 up there, but, Deb, I don't know if we, slide 23 up there, I think it was.
Yeah, workforce.
I love that we're looking at the workforce. One thing that has been proven to, help is actually look at the workforce broken down according to the organizational chart. So at what place in the ripple of the organization it brings together is this workforce broken down like that, and making sure at all levels of the organizational chart, the workforce reflects the demographic of the patient it serves. We look around, we see that here. Just want to make sure, we take advantage of the opportunity to take a look at it in future reports. So thank you. Thank you.
Director Harrington.
Yeah, I don't have a question. I just want to make a point, and I've been listening. I've been pleased with what I've heard. I'm proud of the team here at Cook County, and I want to provide a different type of context because this wouldn't be possible without the emphasis on patient quality and safety that we have. The audit committee, and really not the audit committee, but the audit team to make sure that our fiscal house is in order and is more likely to catch fraud and waste and abuse before it happens. But this requires intentionality. Sometimes that gets lost when you hear the numbers being reported. It requires a degree of intentionality. And so I want to applaud the team for their intentionality toward moving toward quality, knowing that the goalposts will probably move and be further away. So we may never become perfect, but we're as good as we can be, and we continue to strive to be good. But the more important point to make is this is not just the people in this room and the people that do the work in terms of the health and the medical care of patients. It also includes those people to get the meals, prepare the meals, and get those meals up to the room. It also includes the people that move all the people through the hospital. It includes the people that provide security for all of our facilities. And we have around 6,000 employees. And this would not be possible without all of those people. So what may be lost in it is that it's not just the people that are in this room that make this happen. It's the entire workforce of Cook County Health, and they deserve an applause.
I totally agree with you, and the intentionality and also maintaining the integrity is important. And I'll just give an example. Within the last month, I think there's a publication in the Journal of Hospital Medicine, and it again had to do with ED throughput metrics. and these people were publishing how they had improved one of their metrics. A patient gets admitted, so the patient is in the ED hallway, and they move the patient to a ward hallway in the bed, and that counts as they have cut the clock. Now, which patient wants to get left in a hallway? And I never forgot this. There was a leader here who said the hospital he came from, and it's a suburb of Chicago, left without being seen in those years. A patient came in, they took your clothes away. They were not going to leave into the streets. Those were the games going to be played. So to that point, we have always insisted on integrity and actually putting in programs and the rest which actually work and not trying to game numbers. So that's why I'm saying when we get to a leapfrog A, we are really a leapfrog A, not because we just massage things and move this around. Thank you.
Yes, we'll go to Director Sorrell.
Thank you. And I'm just so heartened by seeing these numbers, hearing this report today. So congratulations. Thank you so much for presenting this to us. To the Chief Nursing Officer especially, the engagement, the not only dedication, motivation, and changes that you brought about for nursing are just incredible. And I know along with that decrease in our agency utilization, which is such an important part for nursing, I think that all around not only shores up what nursing does, but particularly while we may be saying is nursing and graduate nursing a profession, we're having these discussions today incredibly enough. We know the profession of nursing and the caring involved with that. So thank you so much for that. I have a question, and I saw the information, and you both provided information in terms of comparisons across the state. But now that we're recognizing that everything is so hyper-local, do we have comparisons related to the engagement across the Illinois Medical District and the other hospitals related to that, such as in these engagement numbers or in some of the numbers that you reported regarding patient care? Because not only will that be very important when we're looking at potentially recruiting strategies, but I think our patients need to know, hey, not only do you have a choice, you have a choice that's truly making a difference when you come in and get help and care. And patients recognize that hyper-locally, there are a number of hospitals that they have to choose from, and we want to make sure that they know that Stroger is right there.
Yes. First off, thank you for the compliments. I do want everyone to know it takes a village. We appreciate the partnership and collaboration with Human Resources, our Quality and our Safety Department, because it does take a lot of team members to make this happen. We do work together in the medical district, all the CNOs, CMOs. We have different meetings where we compare our stats. We share best practices. We would like to really take that to another level. But to answer the question, I do want you to know, we know where each other stands when it comes to quality, when it comes to our safety, when it comes to our patient experience, and we're sharing best practices to make sure that our medical district is represented as a whole as best practices. So definitely we're getting that information to our front line, and our customers know. They come in, they know the comparison, they know what's out there on the website, but definitely I do want you to know there's great teams, and one of the things Donica mentioned was the consistency. We're going to look at some things that fall into Lean Six Sigma workflow processes and improve that, because we have to be consistent if we're going to move that and get to the A from the B. So more to come. Thank you for the comment.
Thank you. Director Robinson.
Congratulations. Your numbers are great. My question is, how does it compare to the other major hospitals in the Chicagoland area? Because your numbers sound fantastic. And the reason why I asked that question is because now I'm going to direct my attention to Pam. This is what I do. You do the clinical, I do the money. So my question is, revenue. Our sources of revenue, as I understand it, we get money from the state / from the county, however it breaks down, and we also have our arm with county care. That's how we get our money, right?
Correct.
Okay. So other thing, it seems like if we have this type of care, that we're really doing a fantastic job. How can we get more paying patients? And that's not taking away from the non-paying patients. I'm trying to expand so that creates more revenue to do more things with. And I listened to what was stated, that oftentimes we don't need to have people physically in the hospital to be able to provide the services that are needed. I think that was stated, correct? So my question is, and this is one of the things we see at Providence too, the marketing of the greatness of the care is not there. So is it possible for us to be able to get the cash in with paying patients by creating a strong and vibrant at-home care?
Sure, I mean, I would say it's possible. I would defer that to the strategy team to determine if that's something we're embarking on for 2026. But there are a number of marketing campaigns that we can have Alex come back and speak to, right, that are geared towards certain populations and getting more patients in. On the finance deck, right, of the finance committee, you will see that our commercial payer percentage to total has grown. Not significantly, but year over year, over the last several years, we have seen that population grow.
Right, and the reason why I'm focusing on at-home care is because if you talk to someone, they may have this perception of what they would experience if they come into county. So, how do we overcome that? If, for instance, this is one thing, and this is when I first came to Chicago, I heard, if you get burned, there's really only one place you want to go if you have a serious burn. Regardless of what you may think, there's only one place you really want to go. And if we have that type of care, and we can now bring that care to the person at home, it could change the dynamics of what we do. So that's my question, that's my charge, to figure out how can we do this better to give us the capability to do greater things, because we surely have the capability, and the nursing is you've been giving the applause because you're more than deserving, and that came from the medical director, so that actually says an extreme amount, because he didn't have to say it, but he chose to say it. And so the care that we've been given, and I think that's what Dr. Fegan was talking about, the care, we do care. That's what we always say whenever I ask a question, we care about folks. And so the idea of providing care to the masses, especially when it comes down to pandemics, should never be compromised and should be discussed. Chair, I really appreciate the strong stance that you took to ask for that. And if possible, I'd like to be included as well, because I think that's a very serious concern that she brought to our attention, because Dr. Fagan, we didn't know. We don't typically address people, but that's the first time I heard it. So I thank you, sir.
Mr. Chair? Yes. Just on the marketing piece, I think it's important before we draw any conclusions on how we're marketing that we hear from Alex, because we're not the target population of whatever the communication is. So especially on things like at-home care, a lot of that is micro-targeted towards the patient populations that would receive it. I'm not saying that there's always more we can do in terms of communicating, especially in a market like this when, the people who have commercial insurance are getting flooded with advertising from Northwestern and UCMC and Advocate, and they buy sponsorships at sports stadiums and things like that. We can't compete on that. Where we can compete is on the communications and marketing that's done direct to consumers. And there's always more that you can do, if you are, and it's revenue generating if you do it right. So Sam may be correct in how we can plow more into it, but I would want to hear that from the team to see what they are doing, because we do see improvements, but it's going to be a challenging space. And one of the places where I think financially it'll become more challenging is in the places where we can make investments in those types of things based on how revenue is going to be disrupted by the Trump legislation that passed back in March, which doesn't have a sufficient accurate name yet. There's a lot of pejorative things things you can say about that bill. But it's gonna continue to pose a challenge, so.
Yeah, and I want to go back to what Pam said. I think we also need to hear where strategy's at with it, because to plow into a strategy that you suggest, I would think would have unintended consequences. You know, capacity is not infinite, so what will that do to uninsured patients or Medicaid patients? And if that means we have to expand capacity, then how do the revenues support our ability to do that? That's what I would just throw as a caution. Was there another hand up before I make some final comments?
What I would also like to add is the fact that we've come a long way in the last year and a half with regards to disposition of our patients. But again, it had to do with the long-stay patients. Most institutions, the average rush anywhere else, they discharge 60% of their patients home. That means that 40% went to an LTAC, SNF, or home healthcare. We were discharging 91% of our patients home because several of our patients were not insured and they couldn't go to the LTACs, the SNFs, and several of those places. I'm pleased to say, because of the program which was put in with the last year and a half or so ago, and credit also goes to Aaron Galina for helping with the process. We've actually been able to put a process in, so we're able to dispose quite a number of those patients out to SNFs and LTACs and so on. So it significantly reduced the pressure. Now, the whole home healthcare space is something that I wouldn't want to discuss because I don't have the expertise on that and so on. But I think that we've made significant growth just by being able to get these patients out to where they need to go. And the whole other thing about the home healthcare, should it happen, should it not happen, and so on, that I agree with Pam. Let's see whether the strategy works, but we've come a long way. And Aaron, thanks for helping us with this.
So I'll just close on a few comments. First of all, I've often said, and recently publicly in this role as chair, that I do believe that the Cook County Health System is a world-class system, and I think this report that you presented today goes a long way to validate that. Donica, I love what you said about, and I subscribe to what you said, that it's not really about chasing numbers, right, or chasing data. And to get to that A rating, if you're doing the things that you're continuing to do, then the numbers will fall where they fall, and the A rating will be there because you're doing the right things. The other thing I think to consider is when we ask the question, how does county compare to either the other partners in the medical district or just hospital or health institutions in Chicago, it's not really a fair comparison, because when you think about the county taking on a disproportionate share of uninsured people, which we know empirically are going to present with more high acute conditions, not every hospital or health system in the Chicago area is presented with the same challenges because of that percentage being what it is at county. You couple that with the types of crisis events that you have to take on and respond to I think Director Robinson's point about, if there's a fire or you've been affected by a fire, where do you go? You go to Cook County. And to have that kind of consistency in how you perform, in addition to what might seem like the day-to-day routine work, it's really phenomenal when you combine those things together. I don't know that there's another hospital or healthcare system that is presented with those kinds of dynamic circumstances.
We're safety net hospital that operates as a large urban direct hospital like Rush.
That's right. Yeah.
And that speaks to the excellence of our team in our hospital. Now, we are not making comparisons to these surrounding ones, not because we are inferior to them, but the numbers and the rest are public. So, because we have the swagger. They know it, whether it's length of stay or anything. We can ask and find out, not just surrounding states and so on. We are that good, and we've done so much. And consider the fact that we've done so much with less, and consider the fact that we know what else needs to be done to even get better, it's nothing short of frightening.
Thank you. And then finally, let me just finish my last comment. Finally, so I think I lost my train of thought, actually, between Bob and what you just said. But
we're supporting you.
Yeah, no, I know. I feel supported, Bob. Thank you. No, I think this is important. And I heard you say, Doctor, that you've come a long way in the last 4 years, but I also believe that this is built on a legacy of 20 to 30 years, 2 to 3 decades of foundational work that's been done by the previous leadership that helped build and get the county to this place, to get Stroger to this place where we can have a presentation like today. And I'm interested to see what it'll look like next year or the next 2 years. And we should never, hold on a second, we should never underestimate that. We should always remember that those people, the work that they contributed to matter as to how we get to where we're at today. Dr. Green, we'll close with you, and then I have to move the agenda on, please.
The American College of Healthcare Executives actually has a white paper, and I can try to look at it. I love the conversations we're having and the different views. One of the things they looked at is it wasn't necessarily marketing. All of them, when more than two things are true at the same time, the opportunity, the things that exist, but the opportunity to move into people who, because yes, they exist. Yes, Dr. Robinson didn't see it. So both things are true. And so I love the opportunity for us to respect that, see the opportunity. And it's also, they termed it under diversity of thought, and it's one of the strongest levers that a board or organization, anyone serving community, can use. So I'm just thankful for this conversation. Thank you.
Thank you. Joe, I'm going to give you 30 seconds, and then I'm
I
going to cut
can
you off.
do it in less, I only have 7 words.
Okay,
We care, and the numbers prove it.
thank you. Okay, thank you one more time.
Thank you so
Thank
much.
you. Thank you. We've got to move on. Thank you.
Thank you very much.
Before we go on to the next presentation, which will be the Cook County Department of Public Health fourth quarter report, Community Behavioral Health Unit, Dr. Joshi, but I want to turn over to Pam. She wants to make a quick remark, please.
Sure, thank you, Chair. I just want to address briefly Dr. Fegan's testimony and assure the board, and I'm not going to say where miscommunication happened, whether it was with medical staff leadership or operations leadership, but from a financial perspective, I can tell you that I validated that uninsured patients are not charged for COVID vaccine. The logic in our system is to write it off, and we validated that that is what happened.
All right, but that won't change the report that I'm asking for by Wednesday. So I'll receive that and then share accordingly. Thank you.
Thank you.
We'll move to Dr. Joshi, please. Thank you.
Thank you, Chair. Good morning, Directors.
Good morning.
Good morning.
I want to just begin with a couple of comments, and then I'll turn it over to my colleague, Hannah Kite, the Director of the CCH Community Behavioral Health Unit. First, I just want to acknowledge and remind you all that last month we presented out on our several ARPA projects, and at the time I made mention of a number of presentations that would follow to dive deeper into a couple of areas that I know are of interest to this board and are certainly of great public health import, so we're following through on that. Second is that I would want you to view this in the broader scope of, or the broader frame of strategic public health priorities. And here we're getting ahead of ourselves a little bit because very shortly we're planning to present to you a report on our 2030 Community Health Improvement Plan. That plan was previously called We Plan. We're changing the name and rebranding. If you're familiar with Healthy Chicago, the Chicago Department of Public Health effort to develop a community health improvement plan and strategy, it's very similar to that, but is you can think of it as the suburban Cook County analog. I mention that because behavioral health is one of the 3 priority areas identified in that strategic plan. And so the strategies are chronic disease prevention, maternal and child health, and behavioral health. So a moment to just share a few words about our journey in this space. And I won't go too long here because I know time is at a premium, but I want the board to be aware that we have been engaged in behavioral health work for almost 10 years at this stage. The unit that Hannah leads was born out of another community health improvement planning effort that we undertook about 10 years ago, where the communities in suburban Cook County told us very clearly that behavioral health was a priority. And so with some really strategic leveraging of resources, we were actually able to bring Hannah on in another position about 10 years ago. And over time, we grew our portfolio of activities, beginning with, again, some really strategic grants that focus primarily on addressing the opioid overdose epidemic. Since then, we have been able to develop a director position that Hannah now fills, and to build a team leveraging funding from ARPA. I want to acknowledge the support of the President's Office, CCH leadership, and this board in supporting us in retaining those ARPA-funded positions, because that will allow us to continue doing the good work that you're about to hear. Finally, I want to just draw your attention to the graphic that is on the slide. This is our attempt to really distill what it is that CCDPH does overall and view the work of every presentation that comes before you through that overarching kind of framework. So what is it that we do? One, we protect health. Two, we prevent disease. We inform the public and engage communities, and we analyze and share data for action. And so here, Hannah is going to speak to you about work that connects with preventing disease through policy systems and environmental changes, certainly informing the public and engaging communities in suburban Cook County around behavioral health related issues. Everything we do, of course, is based on good data, and she'll speak to you about that too. So with that, I'm going to turn it over to my colleague, Hannah Kite.
Good morning. Thank you for the opportunity to present today about the Community Behavioral Health Unit. Today, I'm going to share some highlights from the last year and preview what's ahead in 2026. The Community Behavioral Health Unit works to promote mental health and reduce the harms of substance use. We do that work through outreach and education, through analysis, through resource sharing, which includes grants and other forms of support. And we also engage and collaborate with diverse partners and stakeholders. Yes, thank you. Our work falls into three major buckets. The first is mental health and positive youth development. The second is trauma-informed care, and this is internal-facing work focused on Cook County Health. And the third is opioid-involved overdose and substance use prevention. So our earlier work, as Dr. Joshi alluded to, was in opioid-involved overdose prevention and trauma-informed care. And thanks to ARPA funding in the last several years, we've been able to build a program and establish a program in mental health and positive youth development. And that work includes work in suicide prevention, the crisis care system, and positive youth development. So we work very closely with youth-focused nonprofits and schools to build social emotional learning and resilience with young youth. Excuse me. Next slide, please. So I want to share more about each of our programs. I'm going to start with mental health and positive youth development. Our program builds on decades of community engagement at the health department or with schools, nonprofits, municipal partners, and other community organizations, especially in the south and the west suburbs. We bring together behavioral health partners and foster connections between organizations and to collaborate on shared goals. Our partner convenings are co-designed with community partners to ensure that they're responsive to community needs. So the picture that you see on your screen is some of our team members with our community partners that have helped us co-design our convenings. We share behavioral health resources at community events and health fairs, and with the 20 coalitions and community groups that we are actively a part of. And we connect community partners to other resources from the health department, as well as resources from Cook County Health and other Cook County agencies. Next slide, please. The Community Behavioral Health Unit funds 31 grantees through the Building Healthier Communities program. 27 of these grantees focus on mental health and positive youth development, and half of them are focused on youth. I just wanted to give the board a sort of a flavor of like the kinds of work that our grantees do. One of our key sort of focus areas is promoting social emotional learning and mentorship. So for instance, Girls on the Run works with young girls to promote physical activity and combines it with social emotional learning. They hold very fun events and runs every year, and it's, our team is really always excited to be part of those as well. Big Brothers Big Sisters utilized grant funding to establish a brick and mortar headquarters in the Southland. And they've used that space to really expand their mentorship programs in the South Suburbs. Our grant funding also supports the creation of safe spaces. So for instance, the Village of Hoffman Estates has established a Latina Women's Support Group and does lots of different bilingual events focused on mental health and behavioral health. The Kenneth Young Center hosts a queer prom every year through our grant funding. And they use events like Queer Prom to connect LGBTQIA+ youth with not only behavioral health supports, but legal services and other social supports. We also provide mental health education around mental health and mental health treatment through our grant programs. For instance, Pillars Community Health has hosted events for both parents and teens on executive functioning. And finally, we support the 3 regional offices of education. So this is the regional offices of education that touches every public school student in suburban Cook County. We provide professional development to behavioral health support staff, educators, and school leaders. And then West 40, which serves the western suburbs of suburban Cook County, also engages youth advocates to connect youth with behavioral health supports. So navigating grant compliance is not intuitive, let's say. So we really build in support for our community-based organizations and nonprofits that sometimes looks like one-on-one technical assistance and meetings with them to ensure that they are successful. Next slide, please. So here are some photos from our partner meetings. We alternate meetings virtually and in person to ensure accessibility for all of our partners. This June, and we also try to be responsive to the needs that we're hearing on the ground. So this June, for instance, we hosted a session on navigating grief after suicide in response to a request from a community partner. We've also worked with the Cook County Forest Preserves to host healing and, if you could go, yeah, thank you, host convenings that promote healing and connection in nature. The photos that you see on the left-hand side of the slide were an event in October. We heard from our community partners that, especially during these turbulent times, that these kinds of spaces are really essential. Next slide, please. The Community Behavioral Health Unit also conducts in-depth analysis of behavioral health concerns. Recently, Chief Weber from Proviso Township Youth Services approached us. A community member on one of the committees that he chairs is really interested in learning more about youth suicide in Proviso Township. So our data team conducted analysis of both mortality, death data, as well as youth survey data from suburban Cook County. We found that 15% of high school students reported seriously considering suicide in 2022, and this is local data from the suburbs. We've since shared this report with the Proviso Township's Navigating Mental Wellness Committee, the PT-MAN, which is the Proviso Township Ministerial Action Alliance, and Land 60. And CCDPH was recognized by Proviso Township for this work. Next slide, please. Last month, we released a second report. This looks at suicide in both youth and adults. The report found that while overall in suburban Cook County, suicide rates have not changed, that between 2018 and 2023, suicide rates for African American and Latino residents have more than doubled or nearly doubled. Just wanted to pause for a second and just acknowledge that these are truly heartbreaking numbers, and that everybody, any person that dies from suicide represents a profound loss to a family and to a community. Next slide, please. So as Dr. Joshi mentioned, we take a data to action approach. The suicide in suburban Cook County report includes concrete recommendations and also identifies existing investments that are being made to support suicide prevention. So our Building Healthy Communities grants, by promoting social emotional learning, are building those resilience skills in youth. Our policy team is closely monitoring the implementation of the Safe Gun Storage Act. We also know that this, because our report has also shown that firearms are the leading cause of death when it comes to suicide in suburban Cook County. In the coming months, the Community Behavioral Health Unit is also hosting focus groups with youth groups to better learn more about how youth, where youth want and how they want to receive mental health support. We're also grateful to Commissioner Stamps, who has created Healing Connection through her Shop Talk series. These are events that are held in barbershops and hair salons, safe spaces for our community members. And in the coming year, we're going to be expanding these mental health forums to 6 commissioner districts in suburban Cook County. We are very grateful to the Board of Commissioners for their support and their engagement around youth and youth mental health. Next slide, please. Earlier this week, as Board Chair Garza mentioned, we released a report on the crisis care system in suburban Cook County. The report found that while there's been significant investments made in the crisis care system, especially from the state, that there's opportunities ahead for us to improve awareness of 988 in the crisis care system and to improve coordination and collaboration across the different crisis care providers. I wanted to say thank you to Board Chair Garza, Director Green, and Director Mrs. Burnett for joining us in that press conference and helping to highlight the importance of community voices and the importance of meaningful data, meaningful action on this topic. Next slide, please. So here are the recommendations from the crisis report. There's we worked very closely with over 5 government agencies to make sure that these recommendations were in alignment, not only in alignment and strategic, but also responsive to what we were hearing in the crisis system. So the report outlines both leading supporting organizations that would help carry out the recommendations that are in the report. So one of the recommendations is to invest in diversification and reinforce behavioral health crisis workforce. So we're excited to see our colleagues at the Office of Behavioral Health make great strides with their apprenticeship and retention hub and all the successes that we know that will come from that work. The Community Behavioral Health Unit will be leveraging our networks to raise awareness of 988 in the crisis care system. We're going to be working with the Community Health Worker Learning Collaborative, which is a network of about 30 organizations that have community health workers. This community health worker network represents about 5,000 clients and about 40,000 contacts. So we're really excited to work with this group to help spread awareness of 988 in the crisis care system through trusted community sources. Also coming ahead in 2026, we'll deliver a paid media campaign, use some digital marketing strategies to help raise awareness of 988 in the crisis care system. Both of these reports are in these folders. If anybody, I will pass these out after the presentation, so if you'd like to take a closer look, they're available. Next slide, please. As part of our work to address structural drivers of behavioral health, we are also examining the implementation of restorative practices in schools. So national data shows that high school students who experience unfair discipline are at higher risk for reporting poor mental health, seriously considering suicide, and also attempting suicide. This is maybe a little bit surprising or unexpected. We wouldn't expect someone's experience with suspensions or expulsions to impact your mental health, but there are clear connections between discipline and unfair discipline and behavioral health outcomes. We have found through our analysis that suburban schools have a higher rate of what's called racial disproportionality in their suspension and expulsion rates. They rank higher in the list of, they're in the top 20% of school districts in Illinois that have racial disproportionality in their suspension and expulsion rates. So there's racial inequities in who's getting suspended and expelled at suburban Cook County schools. In the coming year, we're going to be supporting schools in implementing restorative practices, and we're really excited to release the final report that includes an additional analysis. Okay, next slide, please. The second program that I'd like to talk about is our work in opioid-involved overdose prevention and substance use. Since 2020, the Community Behavioral Health Unit has distributed naloxone to over 400 organizations in suburban Cook County. We've trained partners on how to recognize and respond to opioid-involved overdose. Over 180 doses of naloxone have been that we've distributed have been used in naloxone events, and we do think that's an underreporting. The photo that you see on, we also conduct education and awareness events. The photo that you see on your slide is from an event, part of an event series that we hosted in collaboration with the Village of Maywood. As part of an 8-part event series, we trained 65 violence interrupters on how to recognize and respond to an overdose using naloxone, and we also distributed naloxone at the event. Next slide, please. This year, we also expanded our community naloxone box program. Over 40 suburban organizations signed up to host community naloxone boxes, and this includes businesses, community colleges, behavioral health treatment providers, and libraries. Of those 40 organizations, 20 of those organizations were completely new partners to the health department. Again, we also used the data to action approach. So we looked at our data about where the highest zip codes where we were seeing the highest rates of, or the highest numbers of opioid-involved overdoses, and we focused our outreach in those communities. Next slide, please. We paired the expansion of our community naloxone box program with a naloxone ad campaign. So this ad campaign was shared in English and Spanish, in social media, billboards, and in places like with posters in convenience stores and gas stations and other local community gathering spots. So as you can see on the slide, the campaign engaged 1.4 million video views and over 86,000 website clicks. And the videos on the social media platforms and the search engine ad placements surpassed industry benchmarks for this kind of campaign. Interestingly, we found this to be interesting. The Spanish language digital ads outperformed the English language ads, and we think this is partly because of our partnership with Corazon Community Services and other community organizations, especially in the western suburbs. Next slide, please. I wanted to show you some examples of our data and policy analysis work. Our team works closely with our data team at the health department. This fall, we released an opioid data dashboard. So the screenshot that you see on your slide is one of the screens, or one of the views on the dashboard looking at hospital admissions related to opioid events. particular slide shows that while we're seeing a drop in hospital admissions related to 15 to 25-year-olds, that overall 35 to 54-year-olds are the age group that remains the largest proportion of hospitalizations for opioids. Next slide, please. So here's some more examples of our data and policy analysis group. Since 2016, the Cook County Department of Public Health has worked with Chicago's Department of Public Health to issue a joint report on opioid-involved overdose deaths in Cook County. So the image that you see at the center of the screen maps the locations of all deaths related to opioid-involved overdose in 2023. We use this kind of data analysis to inform our work and resource allocation. Early this year, a research brief that we produced a few years ago on overdose prevention sites was cited in Cook County Health's testimony in support of HB 2929 to create a pilot overdose prevention site in Illinois. And although, unfortunately, the bill did not pass, I think this is a great example of being responsive to community needs and ways in which the health department can add value to the conversation. Next slide, please. Last but not least, I'd like to share our work with trauma-informed care. Since 2018, the Community Behavioral Health Unit has facilitated the implementation of trauma-informed care at Cook County Health. We deliver a training on how social and emotional traumas impact our future health and well-being, and we share strategies about how to incorporate that trauma-informed perspective into engagement with patients, clients, and community members. This is truly a homegrown effort. It's a labor of love. We are very grateful to the trauma unit at Stroger Hospital, JTDC, Human Resources, the ambulatory care, and CCH Communications, and many other partners in County Care and many other partners and programs across CCH for helping to champion this effort. We bring together champions across CCH in quarterly collaborative meetings. Like our community collaboratives, we host these both in person and virtually to help ensure more accessible access. At our last October meeting, there was 189 Cook County employees that joined us in that meeting. In the last year, we've trained over 750 Cook County Health employees in the fundamentals of trauma-informed care. Next slide, please. So all of this would not be possible without our exceptional team, Isaac, Candace, Kim, Camille, Monica, Jessica, Joaquin, Alda, Denise, and Lou. I have worked in many different spaces and programs throughout my career, and this is truly some of the most compassionate and passionate people I have ever worked with. Fun fact about the team, most of the team lives and works in the suburbs, or they all work in the suburbs, but they also live in the suburbs. And sometimes this has a real benefits to our programs. Isaac, for instance, he's standing next to me in the photo on the screen. He grew up in Chicago Heights, and his favorite burger place is a place called Peros Burgers. And a few months ago, he walked into Peros Burgers, and he noticed that they had naloxone on their counter, and he was intrigued. So he asked the owner, why do you have naloxone, and had a conversation with them, and then he connected them to our substance use team, and now they're one of our champions in our community naloxone box program. Next slide, please. In the coming year, we will be building on our recommendations in our suicide and our crisis care reports and deepening our work in structural change. So we'll release a report on restorative practices in schools and support school districts in implementing restorative practices. We'll support healing and connection in trusted community spaces through community mental health forums. And we'll be supporting community-based power building organizations, sometimes known as base building organizations, to address structural drivers of behavioral health. That might be something like social inclusion, civic engagement, community alcohol policies, or even paid sick leave, because we know that these have connections to behavioral health outcomes. Next slide, please. So this is what community behavioral health looks like. We are grounded in community. We convene and we connect, and we meet community groups and partners where they are. We are holistic in approach. We work closely with our sister units at the Cook County Department of Public Health and with our sister Cook County agencies and a diverse number of partners to carry out our work and reach our collective goals. We dig deep into systemic issues that drive behavioral health inequities. We want to see truly transformative change, and that can only happen when we address structural forces. So thank you so much for your support of these efforts. Dr. Joshi and I would be happy to take any questions about our work.
Are there any questions or comments? Director Harrington.
Yeah, can you go back to, it's on slide on page 60 in the packet, data and policy analysis, opioid overdose prevention dashboard. Yeah, when I looked at this, and I paid more attention to this than the other slides because it sort of validates what many of us probably assume moving forward, that the groups that are lowest in terms of this are people over the age of 65 and under the age of 24. So there's this issue right there in the middle, which I guess would be the sweet spot that we're looking at. And I don't know what the numbers are, but we do see that there is a significant increase based upon the age of individuals that are involved. And although it's faint, it appears that the second highest is, or the highest is people between the ages of 35 to 44. I can't make out the colors. The 25 to 34, right? Yeah. That's, if you look at all, yeah, the highest number is between the ages of 25 to 34, at least looking at the chart. So there's a way to look at this, and all I'm saying is there's a way to look at this in terms of a strategic approach moving forward. In terms of the populations that are most impacted, you can, and I'm assuming that's what this is all about, data-driven programs that really address the problem. And so this stood out to me, and I just wanted to lift it up. Thank you.
I just, if I may, Chair, I just want to say this is awesome. It's always good to have moments where you stand out. I don't know if we gave you an applause in that earlier, but have moments where you stand out. But to underscore what Director Garza said, when I attended, I got to see how you stand in community, and knowing that it's more important about how we stand in than to have those moments where we stand out. Thankful we're headed over the next couple of years, every 100 years. So we're headed, this is timely, because we're headed into a situation where first people are gonna need behavioral and mental wellness, and that's gonna drive a lot of the other things in the hospitals that we talked about and things like that, either drive it to or prevent some of that stuff. So this is very timely. Thank you for not only starting it, but also having this report where you're looking at it and opportunities to grow, and that is strong work. Thank you so much.
Thank you.
Thank you again, and then highlighting, as Director Green said, this incredible report on the work that you're doing. I really want to thank you as well for recognizing and noting, particularly in your report, the increasing rates of suicide in the Latino and African American communities more recently as well too. We know the high preponderance of other behavioral health issues that were in BIPOC populations, but traditionally suicide numbers were somewhat lower than for white populations until these last few years. We know, unfortunately, now with the recent issues with our government, with immigration and ICE, that unfortunately those are drivers for both increased substance use and increased risks related to suicide. So I'm so thankful as well too to notice that you looked at as your data and policy analysis, making sure that we have all of the tools in the toolbox on the table so that you have a specific notation on overdose prevention sites, which is one of my areas of interest, and I give testimony for overdose prevention sites in Springfield for the bill that's upcoming in this coming legislative session, to recognize that we have proven evidence-based methods that have been able to address these issues issues in other countries, and that it's going to be so important for us to look at the data, to look at the evidence-based practice, and not look at what might be the current narratives coming from some of our other areas, to be able to push forward for these very effective methods of providing care, community, and help, because overdose prevention sites, the use of a substance is less than 20% of the activities. The care, the building of trust, the community, the gaining, all those areas that you talked about last month in your behavioral report, which is why so many people wanted to stay with behavioral health services with us when they left the jail, because they finally got treated like decent human beings for these stigmatizing and otherwise shameful issues related to behavioral health. It's going to be so important to continue to advocate for that. And please let me know anything that we can do to help further what you're doing in these areas.
Thank you so much, Director. 100% agree, and thank you for those comments. I think they're really critical, particularly in this moment.
Any other comments? Director Bott?
Thank you for this wonderful work and all your efforts. I was curious about, as you're digging into the data and policy analysis, is there work that's been done or going to be done around, just to think about the digital and the AI-related impact on suicide and mental health? In some ways, the technologies is critically important and helpful, and it's moving fast, but the mindfulness and the guardrails they have around how it might impact people's mental health.
Absolutely. That's actually one of the questions that we're hoping to ask in our youth mental health focus groups is, do youth have any strategies that they use to sort of healthily deal and sort of manage their social media use? But it's something that we definitely need to think about throughout our work too.
Thank you.
Yes, go ahead.
Yeah. So thanks for both your leadership and driving this work. And I appreciated Director Green's comment, really highlighting how you all are focused on prevention and really looking at the structural drivers and how that complements the work of the Office of Behavioral Health and overall Cook County Health. My question is, you mentioned, I think, the Community Health Improvement Plan, and we know there's an influx of dollars through ARPA that will be ending next year. How are you thinking about the priorities, behavioral health being one, and aligning and strengthening CCDPH's capacity, really thinking about staffing, partnership, resources, especially as you were talking about the engagement of all these partnerships and organizations. So would love to hear that, and I think that's important for us to be aware of.
Thanks for that. I'll take a stab, and I'd love to hear Hannah's comments as well. So thinking broadly about the three priority areas that I mentioned of, again, chronic disease prevention, maternal and child health, and behavioral health. Once again, thanks to the Office of the President, the Board of Commissioners, this body, I want to single out Pam Casera for her support over the past year, which has been incredibly, I think, challenging for all of us in public health and healthcare. I think we're well positioned when it comes to the behavioral health space, when it comes to maternal and child health. When it comes to chronic disease prevention specifically, I think there is opportunity there, particularly when one considers the incredible burden that chronic diseases have on the health of the public in suburban Cook County, which of course is not new and is a national sort of issue. I think there is certainly opportunity for potentially additional investments there, and I will likely be coming back to this body for requests. Thank you.
Any other comments? I'll just add a few. If you've not had a chance to review the Community and Provider Voices study that's up there, the assessment, I would encourage you to look at it, because it'll help give a greater appreciation for this presentation and what they've seen and what they're trying to accomplish going forward. I also want to assure the board that the work is just not limited to the Cook County Department of Public Health as it relates to crisis and behavioral health services. Thank you, Director Bob. I've also had an opportunity, and I didn't mention this in my chair report, I sat down for about 90 minutes with Dr. Mark Nutter's behavioral health team as they're trying to really enhance the models of care around this specific area in the ambulatory care clinics, ACHN, within the county system. Because if they can't get them through the community or one door of Cook County, then there's other doors that we can try to make an impact. And I know that he's committed to doing that, and so is his team. So I enjoyed that conversation last week. If there isn't anything else on this on this presentation, then I want to thank both of you for the outstanding presentation. Thank you.
Thank you.
Okay. So I believe we are at item 9. And so the board will not be going into closed session today. So if there are no other matters, thank you. I have one already. Thank you, though. I did review it too. It's a very great report. So if there are no other questions or matters to discuss, we'll move to adjournment of the meeting. But before I do that, I want to throw a shout out to a young man that served honorably and compassionately in the 2nd District under Commissioner Dennis Starr, who passed away last year, and that's David Evers. David, do you mind standing up? Yeah, David served many years as Chief of Staff, and he's out in the community doing great things to help people from that perspective as well. So it's always nice to see you, David. So as the agenda is exhausted, I will declare the meeting adjourned, and have a wonderful holiday, Thanksgiving, and I look forward to seeing all of you soon after the holidays, and I just hope it's safe and you're able to spend time with family and you're able to rest. The meeting is adjourned. Thank you.